to support this organization, and you can make a donation. I just wanted to let you know exactly where you would be able to do that. As I mentioned, there's over 100 of you live with us right now, but people from across the country are going to be watching the rebroadcast of this. We encourage you to come back to some of the resources and participate and interact with it. We've been discussing awareness, advocacy. We've been talking about genetics, care, and our next segment is going to take us into diagnostics. Knowledge is power, and when it comes to your health and aortic conditions, they're no exception. And we want to make sure that you guys have all of the knowledge that you possibly can gain from one convention like this here today. All right, so let me introduce to you Dr. Kevin Harris. He's a cardiologist with the Minneapolis Heart Institute. He trained in cardiology at Dartmouth Hitchcock Medical Center and was previously the assistant professor of medicine at Washington University School of Medicine. He is a clinical cardiologist and an echocardiographer with clinical and research interests in aortic disease and aortic dissection, valvular heart disease, and heart disease in athletes specifically. Dr. Harris has been actively involved in cardiology education. He served on the University of Minnesota Fellowship Committee prior to helping create the HCMC MHI Cardiology Fellowship Program with colleagues from the Hennepin County Medical Center. He has a long-standing interest in aortic dissection, and in 2005, he brought together the multidisciplinary aortic dissection team. The team created a standardized care approach for acute dissection, which was a new paradigm for the treatment of this high-risk condition, now being replicated at other centers nationally. His research is recognized nationally. He's even been published in over 100 scientific manuscripts and book chapters. Most of all, he enjoys the complete spectrum of cardiovascular care, from prevention of disease to acute illness. He values the privilege to build relationships with patients and families on a continuing basis. Dr. Kevin Harris is going to share with us about diagnosis here. Thank you.
Well, good morning. Thanks very much for inviting me back to this great event. It's really nice to be here. I hope in the future we can do this in person, and I look forward to that. So normally I have a picture of the Minneapolis lakes and sailboats and everything to remind us of summer. But I think this year of all years, it's important that we get outside and embrace the great outdoors and everything that Minnesota has to offer. And especially this week, as it's now above zero, and that's Fahrenheit for those of you not from here. So the way I'm going to approach this is, per Amy's suggestion, is if you were recently diagnosed with a bicuspid aortic valve or thoracic aortic dilation, what exactly that means. And this is a conversation I have in my clinic with several patients, pretty much every clinic. So we'll start with a few words about the bicuspid valve, although I suspect Dr. Benzinger addressed that as well in her talk earlier today. We'll talk about thoracic aortic dilation and aneurysms and what exactly that means, the various things that we think about for causes. We'll talk about medications that can be used and also those that should be avoided. We'll talk about lifestyle, work, exercise, restrictions, as well as pregnancy. We'll talk about the importance of recognizing acute symptoms. And finally, we'll talk about surgical thresholds. So the bicuspid aortic valve was actually first described by Leonardo da Vinci, who's best known for, or well known for the Mona Lisa. And here are his initial drawings of the valve. He also described the flow in the aorta, which he compared to flow in a river, which is really a nice analogy. So a bicuspid valve occurs in about 1% to 2% of the population. So that's 3 to 6 million Americans at any one time. It's more predominant in males than in females. There's a number of different varieties of bicuspid valves, as shown here. It is something that runs in families, so that's an important point that we always cover. If you have a bicuspid valve, a family member may have a bicuspid valve, or they may have thoracic aortic dilation without a bicuspid valve. So that is something we talk about and the importance of screening family members. As you can see here on the right side is a bicuspid valve with the 2 leaflets compared to the normal tri-leaflet valve down below. The various manifestations that we see of a bicuspid valve include progressive narrowing of the valve, which is called aortic stenosis in about 1/3. Aortic regurgitation also occurs in up to 1/3 of patients, typically a little bit younger than those that are developing the aortic stenosis. And patients may also develop endocarditis or an infection of the aortic valve. Importantly, relevant to this talk is that patients with bicuspid valve may also develop aortic dilation. And these are not mutually exclusive. You can have aortic stenosis and dilation or one or the other. On the right side here is a patient of mine with a bicuspid valve, and typical for the dilation seen with bicuspid valve, the greater degree of dilation is a little bit further up the ascending aorta than compared to right. This is the aortic root, and I'm going to show you some other images later. The aortic wall in the bicuspid valve tends to be inherently weaker and have some characteristics that lead to the dilation, and some people believe that the turbulent flow and altered flow pattern in the aorta is shown here compared to the normal aorta also contributes to this. But regardless of the mechanism, if the ascending aorta is not well seen by the echo, then a CT or an MRI should be done to further visualize the higher or the distal part of the aorta. And once aortic dilation is recognized, then lifelong surveillance is needed, especially if it's above 4 centimeters. So this is a figure that demonstrates the aorta, and I like this movie because it demonstrates dilation of the ascending aorta and then a descending dissection. So the various parts of the aorta, the first part of the aorta is the sinus valsalva, or the aortic root, right above the aortic valve. Then we have the ascending aorta, which is very dilated in this particular patient. The aortic arch, which gives rise to the great vessels, which supply the neck and the head. And then finally, the descending aorta. So we're going to focus today primarily on the aortic root as well as on the ascending aorta. So we as the physicians rely for guidance on studies, and every few years these are summarized in these consensus statements that come out from the American College of Cardiology and the American Heart Association based on the latest evidence. So much of the data that I'm going to talk about today is still reflective of the 2010 guidelines for thoracic aortic disease, which are now, as you could tell, 11 years old. There's also a more recent European guidelines. We also have some imaging guidelines, which we'll refer to. But in contrast to the valve disease guidelines, which were just updated in December of 2020, the aortic guidelines are currently being revised as we speak. So we'll have that information hopefully next year when we talk again. I've had the opportunity to be part of the IRAD group, which is the International Registry of Acute Aortic Dissection, for the last 15 years. And some of the data that I share with you today will be a result of this great collaboration that was started many years ago, and provides information on what we're trying to avoid here when we diagnose an aortic dilation or aortic aneurysm. So what is an aneurysm? Well, basically it means that there's dilation of a blood vessel compared to the normal diameter. An aneurysm, technically, it means that it's 50% bigger than it should be. These are always or generally silent. There's generally no symptoms associated with aneurysms, and they're often detected incidentally as part of some other imaging process. Knowledge is important, though, and patients are concerned when they get this diagnosis, but I try to emphasize that it's important, and it's way better that we have this information and we can make positive impact and get patients on the the right medicines in advance rather than to discover this in the midst of a life-threatening emergency. This image that I have here in the lower right is a patient I just met recently. He's a patient with Marfan syndrome, and he has the typical dilation at the aortic root of the sinus of Valsalva. It's approximately 4.8 centimeters, much larger than it should be for the young age of the patient. So when we measure the aorta, and you can see here, this is a similar diagram of the echo view that I just showed you, called the peristernal long axis view. And we measure the aorta in a number of different places. First of all, in the sinus valsalva, or the aortic root, as indicated here. This is called the sinotubular junction, and then the ascending aorta. So when measurements are made, they should be reported as to where that enlargement occurs. And we generally want to report them perpendicular to the flow of blood. And I'll show you what that means on a future slide. We like to make comparisons to prior measurements. And quite often when I'm seeing a patient and they're diagnosed with dilation, I look back for past images and ideally the images, and I can make my own measurements and see if it's really changing over time. We prefer to use tests that minimize radiation. So I'm an echo person. I like to do echo, especially if the dilation is right close to the aortic valve. MRI also is a test without any radiation. So when we talk about dilation, it's important that we recognize what the normal aortic size is for somebody of your gender and your body size. So this is a nomogram that I use for pretty much any time I'm questioning how to describe the aortic size. So this is for men, and there's also one for women, of course. This is the sinus of Valsalva measurement. And you can see the size of the aorta here on the vertical axis and the age on the horizontal axis by various body surface areas. So most people are going to be between these lines. And you can see as men get older, their aorta gets bigger. And again, what's normal for an older man might be highly abnormal for a younger woman. So imaging of the aorta, we've talked a little bit about echo, which is a very easy test to get performed. We also have MRI, and this is the patient with the bicuspid valve and the dilated aorta, and she subsequently had an MRI to confirm that she had dilation of her ascending aorta as shown here. And what the reader can do then is scan through and measure it perpendicular to the flow and get the largest measurement. This is also a CT image, actually the same patient, showing the aortic dilation again. So a very precise way of measuring the aorta. It's important to recognize that the aorta does not generally grow at a great degree yearly. It's usually, for most people, stays the same. The overall population studies have shown that it's 0.6 millimeters per year. And in my personal experience, it certainly seems much less than that. It's rare that I see big jumps, but I definitely see that. And that's the point of doing follow-up imaging. So once we recognize that the aorta is dilated, we generally repeat the image in 6 months and then annually. And then if the aorta is on the smaller side, it may go to every 2 years. If it's on the larger size, then we may stick with the 6 months. This is a really nice study for anybody that interprets the size of the aorta. And it just came out recently, and it talks about why there are these discrepancies in the measurement of the aorta. Particularly in young people, the aorta expands when the heart contracts, and that's called systole. And is the aorta being measured at a particular time in the cycle, systole or diastole? Is the reader including the wall of the aorta, which is thin but still can add a couple millimeters to the measurement? And we have standards for echo, but there's no such standards for MR and CT to my knowledge. As I talked about earlier, it's important to measure the aorta perpendicular to the flow of blood. So again, a measurement would be made here versus here, which would give you a larger measurement. And probably the biggest source of variability I see is, how is the measure made at the sinus valsalva? Is it made from sinus to the commissure or sinus to sinus? So it's important that the reader communicate to the ordering physician how their measurements are being made. Having said this, the growth of the aorta and the risk of any adverse events is actually relatively low at smaller aortic size. So this is a nice study from the Mass General Hospital showing the probability of dissection or rupture on the vertical axis at various aortic sizes. And the percentages that you see are over 5 years. So if you have a small aortic aneurysm, let's say, that's less than 45 millimeters, your chance of having a problem over a 5-year period is actually relatively low. And I'll talk a little bit more about that later on. So when I see a patient or patients refer to me with the dilated aorta, what do I think about? What is the cause of this? Many aneurysms are going to be degenerative. They're going to be due to risk factors such as hypertension, perhaps uncontrolled hypertension for a number of years. On our checklist, but I must say are relatively rare, are inflammatory diseases related to the conditions I've listed there, and also infectious causes, again, relatively rare. But really what we're trying to understand, is there a genetic etiology for the aneurysm? And I believe that Gretchen covered this morning Marfan syndrome, the most prototypical syndromic cause of aortic aneurysms. And so the syndromic would be patients that have aortic dilation, but they also have something going on. In the case of Marfan syndrome, they have long extremities, they have a chest wall that caves in or sticks out, they may have scoliosis, ophthalmologic or skin issues. And so they have a number of other features. And there's other conditions that have other syndromes associated, as I've listed here, and I believe was covered earlier today. But there's also these other genetic causes, such as the bicuspid valve, which we discussed. There's not a specific gene that we know we can test for, but and also these familial thoracic aortic aneurysm syndromes. And these are the genes most typically associated with that. So if we have a family that has multiple family members that have dilation, we should be thinking about these genetic causes. Having said that, we find a gene in about 20% of affected families. Okay, so what do we do once we have the diagnosis of aortic dilation? Well, I think the most important first step is I try to understand what the patient's blood pressure is. And if it's at all elevated, we treat it to normal ranges. So the first evidence for beta blockers was actually in turkeys, which are prone to aortic dissection. And they basically gave turkeys beta blockers and showed that it decreased the rate of the aortic pressure increase and decreased the risk of dissection. There's also really good information. Years ago, this study came out in the New England Journal looking at patients with Marfan syndrome and giving them beta blockers. And again, very, very good evidence for beta blockers in Marfan syndrome. Similarly, there was nice experimental evidence for ARB, or the angiotensin receptor blockers, in Marfan syndrome. And a couple of years ago, there was a there was a series of head-to-head trials looking at atenolol, a beta blocker, versus losartan, and ARB. And I think the take-home point is both are good. If you had to choose one, the beta blocker may have certain advantages. However, I think we extrapolate for any other aortic condition that we're talking about from the Marfan population. This is the population that is best studied And I think these are my first line drugs. If somebody has Marfan syndrome, there's a signal of harm with calcium channel blockers. We try to avoid that in that specific indication, though they're really good blood pressure drugs. But that would be the way we would approach it. I often ask the patient to record their blood pressure at home, so we have realistic readings of what they're doing in real life. And the dogma would be treat to the lowest blood pressure the patient tolerates, but generally, certainly, I would want it less than 130 and less than 80, and ideally much lower than that. Smoking is absolutely something that we do not want our patients with aortic dilation to be doing. There's a number of resources, and as many of you know, Minnesota sued the tobacco companies. They have a free resource for patients to help them quit tobacco. There's other resources as I've listed here, but this is tobacco is not good for the aorta. I just mentioned the statin drugs, particularly in the older patients that have other atherosclerotic risk factors and have an indication for other reasons that they would need to be on a statin. There is some evidence, and there was a warning against the fluoroquinolone antibiotics a couple of years ago from the FDA. And so part of my counseling with patients is to say to avoid these antibiotics when at all possible. There was also a study just from a little over a month ago looking at fluoroquinolones in patients older than age 35 who subsequently developed aortic aneurysms, for the most part abdominal aortic aneurysms, but still another reason to look for other antibiotics if at all possible. Okay, so what about lifestyle and work? I think the take-home message when I meet with someone is try to understand what do they do? What do they do at work and what do they do at home? And generally what we try to recommend is against any strenuous lifting, pushing, straining. And it's really hard. I often get asked, what is the specific weight limit? But that kind of comes down to what the patient feels comfortable doing without straining. And that may include the work situation. So not a lot of risk here for an office job. But if a patient, for example, had a job where they're lifting heavy things all day long, that might be a reason to have a conversation. But generally, and I have farmers where, I try to understand, can they get help with certain activities? Is it lifting the water softener bags or whatever it is in their home environment? And it is important that the patients take their medicines. This is a lifelong condition. And it's always surprising to me when I learn the patient has come off their meds in the interval since I've seen them last. There's been some interesting studies that have come out about athletes and aortic dilation, and we do know that chronic exercise may actually increase the aortic diameter. There was a nice study, this is from last year again from the Mass General, where 21% of endurance athletes had aortas greater than 4 centimeters. Now, whether this has the same adverse prognosis in other patients that might have the similar degrees of aortic enlargement, we don't know that. This is still pretty preliminary. We also know that this is a study from the NBA basketball players. We know that the aortic size is bigger as fits with their body size, but large increases are unusual. So, and as you can see here, most athletes have some mild and moderate or mild enlargement of their aorta, but nobody is really larger than 43 millimeters, which would be felt to be abnormal. I did have the opportunity a couple of years ago to work on this American Heart document, which looks at what physical exercise is potentially harmful in patients with aortic enlargement. I think just a couple, and sports are graded based on their dynamic and their static components. I think just a couple quick take-home points from this is weightlifting should be avoided when possible, and that would be heavier weight. So anything that requires straining, we try to avoid. And there's been actually studies that show that your systolic blood pressure can go up to 380 millimeters with significant straining. If patients want to do some light curls and things that they can do many times, that is generally felt to be okay. And again, sports that involve a chance of bodily collision should be avoided. And we have specific recommendations in this document for various sports and based on your condition. So for the most part, any of these sports, curling, golf, bowling, are going to be safe, but all the further details are spelled out in that document. So women with Marfan syndrome or other causes of aortic diseases should be counseled regarding the risks of dissection prior to conception. Once the patient is recognized as having aortic dilation and is pregnant, the blood pressure should be followed closely. They need surveillance during pregnancy. Usually that includes periodic echoes, and they should be delivered at heart pregnancy centers. There's a nice document from the European guidelines as far as particular sizes at which there may be an increased risk for both Marfan syndrome, for the bicuspid valve, but a lot of this really comes down to shared decision making. There's not a lot of data out there. This is a study we did with our IRAD group, just published a couple months ago, looking at dissection in our IRAD population, a large population of dissections. It was relatively rare, 0.3% of all our dissections. Average age was 32. About half were during the pregnancy and the rest were postpartum. And interestingly, 69% of these patients were discovered to have an aortopathy or a family history of aortic disease. And in half the cases, it was diagnosed at the time of the dissection. So as far as the surgical threshold for sending aortic aneurysm, well, this is really based on some of those natural history studies. And this is a study from Yale looking at the aneurysm size here on the horizontal axis and the probability of complication here, because that often occurs closer to 6 centimeters. For many years now, we've had the criteria of elective surgery at 5.5 centimeters. And as I shared with you earlier, size is going to depend on various other factors, including your gender, your body size. And so I think there's other things that need to go into this equation. I'm sure my colleague, Dr. Cavalcanti, will share some novel area to height ratios, which are being proposed for a part of that equation as well. Other things that potentially could signify a need for sooner surgery would be growth greater than 0.5 centimeters or 5 millimeters a year. Pretty rare, but I've seen that. Or any symptoms suggestive of expansion. If the patient is diagnosed with one of those genetic syndromes, then surgery can be performed at smaller sizes than 5 centimeters. For bicuspid valve, however, it still is 5.5 centimeters. If the patient needs an aortic valve replacement, meaning the surgery is being done because of severe aortic stenosis, let's say, and the aorta is 4.5 centimeters, that would be an indication for surgery. As I said before, it is important that the patient realize that they were given this diagnosis, as Fred Hoiberg was at the end of his playing career for the Timberwolves. This is John Ritter, Lucille Ball, both of whom died of aortic dissection. John Ritter, in his case, although his aorta was dilated on a CT scan, he was not aware or advised for a routine follow-up and unfortunately died during an angiogram. when he presented with severe abdominal pain. So his widow, Amy Asbeck, has actually made it part of her mission to educate physicians and patients about the importance of coming up with this diagnosis. So it is critically important for those of you that are listening to this today that you advocate for your own testing, and that the worrisome symptoms, and I always have this conversation the very first time I meet with someone, is if they are ever to develop any severe symptoms such as chest, back, abdominal pain, the aorta goes through your whole body, so the pain can be anywhere, to seek immediate medical attention. High-risk conditions include any of the situations we're talking about today: a personal history, a family history, aortic disease, aortic valve diseases, even prior surgeries or prior cardiac catheterization, for example. And once you go to the emergency room, it's not enough to just get an EKG or a physical exam. Chest imaging should be performed. And this is actually really spelled out well. And these are a little older now, but these authors wrote a series of articles for the Wall Street Journal that actually won the Pulitzer Prize. And one of the articles details an unfortunate situation of a young man that went to the emergency room many times, and unfortunately his aortic dissection was not diagnosed until after it was too late. The issue with an aortic dissection is there's a tear in the wall of the aorta. The innermost layer separates out, as you can see here. This is what's called the intimal flap, and leads to these two paths that the blood can go. And the mortality for this condition is 1% per hour. So we want people to go in right away. I know that COVID-19 is being covered in a different talk, but I just wanted to say a couple of words. So early in the pandemic, there was controversy. We got numerous phone calls about blood pressure meds, particularly the ACE and ARB meds. COVID actually attaches to the ACE receptor, and there was speculation that it actually may be harmful. Numerous studies have now shown that not to be the case, and blood pressure meds are safe, and in fact, some people now think they may be protective. Another point is there's been a fall in acute dissection cases in the COVID era, and what that means is that we suspect is patients are perhaps not seeking attention and having their dissection and perhaps dying at home. So as I said on the last slide, the importance to seek medical attention with severe symptoms. What about COVID and the risk if you have one of these aortic conditions? In isolation, we are not aware at the present time that aortic disease itself is a high-risk condition. Unless there's a heart failure, a severe valve leakage, some other lung disease, certainly, that also predisposes you to risk. And we would advocate that pretty much everybody that is eligible get the vaccine, as the benefits significantly outweigh any risks. So there's a number of important patient advocacy groups out there. I mentioned the John Ritter Foundation. The Marfan Foundation is an incredible resource that has really good information on its website. And then, of course, Rock from the Heart. Here we are a couple of years ago. This is Amy, John Ritter's widow, Patty Peterson, one of my patients, who's made it also a mission to educate patients about aortic conditions and heart disease in general. So I hope today we were able to relay some good information for you. We did talk about imaging, the various tools that we use, both echo, CT, and cardiac MRI, how I define the degree of dilation and the importance of follow-up imaging. Growth tends to be rather slow, less than 1 millimeter per year. I listed the various causes and particularly the genetic syndromes that we're on the lookout for when we make this diagnosis. We talked about medications and blood pressure control, including my first line drugs, including beta blockers primarily, and then ACE or ARB as second line, but realize we're extrapolating from data from Marfan syndrome. We try to avoid fluoroquinolone antibiotics when we can. We give statins to eligible patients that have other reasons to be on these drugs. Smoking is absolutely contraindicated. We talked about some various lifestyle and work restrictions, but really, for the most part, avoiding severe isometric exercise. It is important that patients recognize and advocate for their own testing if they have severe symptoms. And we talked about surgical thresholds for surgery. So with that, thanks very much for inviting me to be part of this conference, and I hope this was useful.